Okay, welcome back to the second pharmacology lecture. As I've said, snappily entitled Cardiovascular Pharmacology 2. Nice and clear. What we're going to look at today though is pharmacological interventions more associated with the rhythm of the heart. So what we've got here is, we've got the electrical changes that are moving across the surface of the heart in relation to the electrocardiogram down here in the bottom right hand corner. The ECG trace is made up of the P, Q, R, S, T components. So we've got the P wave at the beginning here. Now the P wave is when the atrial depolarization is happening. That is, the chambers up here are contracting. Then we've got the QRS component, and the QRS component is when the ventricles are contracting here. And then the T wave is the repolarization of the ventricles. So we've got atrial depolarization, ventricular depolarization, ventricular repolarization. You're probably now thinking there's one thing missing, and that is the atrial repolarization. That would be a very, very small peak, and it's actually occurring here and is completely masked by the QRS wave of the ventricular depolarization. So what we've got to happen then is, you've got the pacemaker up here, the sinoatrial node, that sets the beat of the heart. That sends a wave of excitation over the atria. They contract, and so that wave of excitation, as they become depolarized, is picked up by the ECG trace there. The wave of excitation then reaches the atrioventricular node, which carries the electrical impulse from the atria to the ventricle, and it spreads down through the Purkinje fibers. And that sends the wave of excitation over the ventricles, causing them to contract. Ventricular depolarization as these cells become excited. Okay? And what we've got here are just the timings in milliseconds for the whole journey to take place. And that's really showing you the wave of excitation as it moves along, moving down across the heart. You get that contraction, excitation, spreading over the surface of the heart. That's just putting it into the context of the contraction of the parts and also the heart sounds. So just to show you how these all align with the ECG trace, the heart sounds of the bicuspid and tricuspid valve closures and the aortic and pulmonary valve closures there. So that's just to put it all into context. So when you look at a cardiac muscle action potential, that differs from a neuronal action potential in one key characteristic, and that is this bit here. Think of an action potential. That's the sodium entry, and that's the potassium exit. Sodium, potassium. Up and then straight down. What you notice here though is when you get to this part here, let's take this one for a minute. This part here, where you get almost an equilibrium, a balancing, that's because there's a calcium channel involved in cardiac muscle. And at the same time as you're getting the potassium exit, so you're losing positive charge, starts to come down, the calcium channels open and calcium goes in. And for a period of time, you get the influx of positive charge from calcium balancing the efflux of positive charge from the potassium. So calcium going in balances potassium coming out, until eventually at this point the calcium channels close and potassium continues to leave. That gives you the prolongation of the action potential. So a neuronal action potential contains, that happens because you have sodium and potassium channels active. Cardiac action potentials look different, more prolonged because of that extra involvement of the calcium channel. Now, The heart has a natural rhythm that's all controlled by the pacemaker. If you get an arrhythmia or an abnormal rhythm, that comes about for a variety of reasons, one of which could be an abnormality in the impulse generation. That is, the pacemaker's not firing the way it should. Or you get an overexcitability of the heart. It's firing at too quick a rate. Or that conduction system that we saw, which was the wave of excitation spreading from the pacemaker to the AV node, from the AV node down the Purkinje fibres and across the surface of the ventricles, an abnormality in that conduction system. Again, I'm just going to have a wee quick look at the screen here. I've got a feeling these may be quite difficult to see on the screen. You can just about make them out with the red peaks. That's just showing you, if you like, a disorder of impulse generation caused by an ectopic focus. That means that you get a natural. So if you look at the 1, 2, 3, 4 peaks, the first 4, they have all got the same shape. And then if you look at the 5th one, it introduces a little extra wave, an extra P wave there. And that affects the rhythm. That, if you like, it's a premature contraction of the atria that's the problem there. And that's what you're seeing over here in this area here. You can also get a ventricular tachycardia. Now, for this one, you've really got to compare the previous one. If you look here, you've got 1, 2, 3, 4 blocks between the peaks. You look at this one, and you've got 2 blocks between the peak. It's almost like it's firing twice as quickly. So you get that tachycardia. Tachycardia being an acceleration of the heart rate, bradycardia being a slowing of the heart rate. So this is evidence of a tachycardia, meaning it's firing much more frequently than it should be. You then can get what we call ventricular fibrillation. Now, ventricular fibrillation, if you think about it, let's do a wee bad drawing here. Imagine for saying's sake that's the heart there, right? My drawings are dreadful, but just live with it here. And you've got the pacemaker up here, right? And then the excitation spreads down to the AV node and then spreads out over the ventricles. Now, if every single cell in the heart, every single cardiac muscle cell is myogenic, meaning it has the potential to generate its own beat. Now, if you get the pacemaker sending out a wave of excitation, and then a random cell down here sending out a wave of excitation, which it shouldn't be, where they meet, you get almost like a kind of anarchy, chaos. The two of them collide, and instead of the beat being controlled, instead of the atrioventricular contraction happening, you get the heart going into fibrillation, where it almost just vibrates. And that can be seen there. You've lost the natural rhythm, and it just does this. That often occurs after, say, a heart attack, when the blood gets reinstated to the cells that have been quiescent during the occlusion of the coronary arteries. And therefore, how do you fix this? Well, one way to fix ventricular fibrillation is to defibrillate. You know, when you get the old defibrillator on the chest. Now, the purpose of the defibrillator is not to make the heart go back to beating this way. The purpose of the defibrillator is to stop the heart stone dead. And once it's stopped stone dead, the hope is that the pacemaker will pick up the beat again. And that's why, now, the kind of power they're putting through there, the energy that they're putting through the heart in order to get it to stop, is equivalent to the amount of energy it would take to light a large football stadium. So, for example, in Edinburgh we have Murrayfield Stadium where the rugby is played. The amount of energy that's used for all the lights in Murrayfield, including the floodlights, that's the amount of power that you batter through the person's chest in order to get it to stop. And then hopefully the pacemaker picks up the natural rhythm again. The other thing you can get is what we call heart block, and that's where that We said that the wave of excitation, pacemaker sets the beat, passes down and spreads over the atria, causing them to contract, and then goes through the AV node and the way it spreads down through the ventricles. Heart block is when that AV conduction doesn't happen well. So therefore, it's difficult to pick up the beat of the heart to increase the wave of excitation that you need. The other problem, you can get what we call re-entrant tachycardia, and that way, that's when you get, the muscle contractions are poorly contracted. They're not coordinating properly, and that can be caused by cardiac cells that have become damaged, and you get basically an accelerated heart rate as a consequence of that. Now, when you see the heart block, what happens is the PR interval is prolonged. Thinking back, remember I said that before the gap between the peaks was four boxes, if you like, on the scale, and then when we got the tachycardia it became 2. Here we've got 1, 2, 3, 4, 5 boxes as a difference, showing you that it's taking longer between the peaks, and that's because of the heart block, that difficulty in getting the signal to pass to the ventricles to get the peak contraction of the QRS wave happening when the ventricles contract. Now, there are a whole variety of anti-arrhythmic drugs that are all there to modify and, if you like, fix the abnormal rhythm and conduction mechanisms going on within the heart. Yep. So you've got to be very careful with them, because they can go the other way and they can actually cause contractility and rhythm problems. Yep. They're classified according to the Von Williams classification, and that classification is dependent on what they do to the action potential, and we're just going to nip through those now. So, class 1, slow the rate of entry of sodium into the cell. Yep. So what you're doing there, that increases the refractory period and decreases the AV conduction. So that will slow the process down, because this bit here takes longer with these drugs. Quinidine is an example over there. We then have, this is again showing you what we mean. There's the normal rise, and this is going to take longer because it's slowed down because of the action on the sodium channels. And if that takes longer to reach the peak, it'll take longer to come back down, longer to return to baseline, and therefore longer before you can fire another one. Class 2. Class 2 prevents the action of the sympathetic stimulation. They slow basically, they're slowing the pacemaker. An example of class 2 would be, for example, like the beta blockers, slowing everything down to when you've got an accelerated rhythm. Class 3, they act on the potassium channels. So what they do then is they lengthen the duration of the action potential. So whereas your class 1 caused the sodium rise to be slower, therefore lengthening the whole thing, class 3 make the potassium outflow slower, lengthening the whole thing. And that's an example. There is Rutilium is over there, and also amiodarone is another example. Class 4, nice and simple actually, calcium antagonists. They block the calcium channel. Therefore, the calcium entry that come in here is going to counterbalance this. You get a change there. But also, primarily, what they do is they also block the calcium channels in the cardiac muscle, reducing the force of contraction. So therefore, they can be quite advantageous when used against a problem where there's an ectopic beat, an extra beat. If you're reducing contraction, you can suppress the ectopic extra beats. Now, other things that you can do is you can, give radio frequency energy. You can via electrodes. You can, if there's a part of the heart muscle that appears to be damaged and that's causing the problems, you can have a surgical removal of that. you can put a little indwelling defibrillator which picks up the rapid rate and the rhythm and immediately gives a little shock to the system. These shocks are because they're right on the heart, are much lower intensity than the one that's battered through your chest if it happens, after a heart attack or something. That's just showing that the cardioverter defibrillator in its position in a chest X-ray. I'll take one of my wee strolls round the back of the camera to see what it looks like for you. Yeah, you can kind of see it there. It's over there on the right hand side over here. This bit here that you can see just there. That's your defibrillator. Yep. Recognises, it detects the tachycardia and delivers a little shock to the heart. It's not massive, but it can still be seen as a painful twinge, and people can, recognise it. So those are ways to deal with this idea of an abnormal rhythm. Another common problem that we want to finish off and look at is angina. Angina being that pain in the chest that comes in with exertion. So, basically, you have the heart working at a level. And if it's working at a particular level, it will demand a certain amount of energy. And that energy comes in the form of oxygen and glucose. You get angina when the oxygen demand is not met by the oxygen delivery. This is a problem with the blood flow to the heart. So this is a problem with the coronary blood vessels. As you're well aware, the blood that's contained within the heart in the ventricle that's going to be pumped out is of no use to the cardiac muscle itself at that time. It has to be pumped out through the aorta, distributed through the coronary arteries, and come back to the outer surface of the heart, thereby giving the oxygen to the muscle. So what happens is, the heart works, the coronary arteries can't supply enough oxygen, they then go from aerobic into anaerobic metabolism, you get the build-up of lactic acid, you get a pain in your chest. That's what angina is. Now, how does it come about? Well, you can get a stenosis, which is an abnormal narrowing of the vessels, in the coronary vessels, or you can get a vasospasm where the walls contract. So either way, the blood vessels, coronary arteries, are unable to supply the correct amount of oxygen-rich blood to the cardiac muscle. How are you going to treat it? I suppose it's very simple. If the supplier doesn't meet the demand, you get two options. You either decrease the demand or increase the supply, or win-win situation, do both. So you need to reduce the workload, therefore reducing the demands, or you need to improve the delivery of the oxygen. So, the first group we're going to look at are the Nitrile Vasodilators. Glycerol trinitrate. Bear that in mind, it's glycerol trinitrate. A few years back, many years back now, I had one of my students tell me that trinitrotoluene would be a very good nitrile vasodilator. The trinitrotoluene is TNT. It probably would solve your vascular problems, probably blow their heart out your chest, but it's glycerol trinitrate. Now, these drugs are what we refer to as prodrugs. Now, we mentioned them a way back at the beginning. That is drugs that are given that in themselves are inert, but the metabolic processes within the body convert them to an active ingredient. So your nitrile vasodilators, like glycerol trinitrate, that gets converted within the body to nitric oxide. Nitric oxide activates guanylyl cyclase. That increases the levels of cyclic GMP. As the cyclic GMP levels rise, calcium entry is prevented. Calcium levels within the heart muscles, in the smooth muscle, the blood vessel goes down. Because there's less calcium, you don't get constriction of the smooth muscle, you get relaxation. Smooth muscle relaxes, vasodilatation, increased blood flow through the coronary arteries. So these ones are about increasing supply. And that's just a little diagram for you to look at in your own time, just to get your head around what we're talking about, this idea of the nitrate being a nitric oxide donor. You can pause the film here just to take a look at that if you want. The other thing we can use are the calcium channel blockers. Again, they're preventing the entry of calcium into the smooth muscle. They block the calcium channel in the smooth muscle membrane. Calcium can't come in. Calcium can't cause the interaction of actin and myosin. If there's no interaction of actin and myosin, you don't get constriction, you get relaxation. Blood vessel relaxes, again, increased flow. So again, the calcium channel blockers are all about increasing supply in the same way as the nitrile vasodilators were. The beta blockers is another one. The beta blockers, are going to work on the beta 1 adrenal receptor, and what that will do is that will reduce the rate and force of contraction of the heart. You don't get the sympathetic drive. The heart is not working at the level it was before. So what these are doing is these are going to increase the workload and decrease the workload and therefore decrease the demands. So your nitrile vasodilators, calcium channel blockers are all about increasing supply. The beta blockers are about reducing demand via the reduction of workload. And again, another one of the little diagrams showing you how the beta 1 adrenal receptors leads to contraction, and by blocking the beta 1 adrenal receptor you reduce contraction. And again, if you wish, take a little time, pause here and have a wee look at the flow diagram. But this is evidence of a G protein coupled receptor, which we mentioned way back in one of the first earliest lectures. Now, you might well have heard of people with angina because they might have, in order to reduce the risk of a subsequent heart attack, been given aspirin. Aspirin, this is a totally different, this is, not 2 aspirin like you would take for analgesia. This is like a quarter of an aspirin, a very small dose. But it's a dose at a level that will not necessarily affect the prostaglandin production within your body, but it can have more of an impact on platelet aggregation at the low dose level. And if you don't get platelets aggregating, you're less likely to have a clot in a blood vessel, therefore your coronary arteries are more likely to remain patent with the blood flowing through them, thereby reducing the risk of myocardial infarction. Other things that you can have, more surgical things, you can have an coronary artery bypass to go around the damaged vessel. You can have transarterial coronary angioplasty, where you blow the thing open with a balloon to get the flow improved. These things would probably be used if an individual patient was found to be unresponsive to the pharmacological manipulations that we've already spoken about. And that's just some little diagrams showing you the angioplasty. They're not particularly clear for you, but it's to show you what's actually done, and you can just take a little bit of time to look at those yourself. A stent can be put in, which is a little bit almost like scaffolding. You feed it in, you open it up, and the meshwork supports the blood vessel around where the blockage might be, therefore allowing the vessel to remain patent. And then your bypass is where if you've got a damaged vessel, then basically that's a triple one. What that's doing is the vessel that would normally be supplying this area is damaged or blocked. So what you do is you bring off branches from other vessels into the ventricle area to increase the supply to the ventricle, to therefore, as I've just said, increase supply. So what we've seen there today is we've looked at the fact that the heart can develop an unnatural rhythm, and there are a variety of ways, the class 1 to class 4 antiarrhythmic agents, to get that fixed. We've also then had a look at the angina problems, and angina where you get this difficulty in maintaining a supply of blood through the coronary arteries to meet the demands of the heart's workload. And you get 2 opportunities to fix that. You can either increase supply or reduce demand pharmacologically. So we looked at you should be able to then think about the action of the nitrile vasodilators and the calcium channel blockers, which are all about vasodilatation of the coronary arteries in order to increase supply, or the beta blockers to stop sympathetic drive in the heart to reduce the workload of the heart. That's their approaches. And then we mentioned at the end things like stents and bypasses that can be used to improve the flow and delivery of oxygen to the ventricular tissue when the drug approaches that we've already mentioned have been less successful than anticipated. Thank you.